is going to talk about concurrent disorders during pregnancy. And these are conditions that you have prior to, and you prior to getting pregnant that can impact the pregnancy for the mother and for the fetus. So for all of that. The next chapter has to do with conditions that you have to be pregnant to get first. So these are conditions that mom can have that will impact her pregnancy, and her fetus, and possibly even carry over into the status of the newborn. But before we start looking at that, what I thought we would do is take a little quiz. And we're not really going to take a quiz. We could have, I guess, but we're not. Okay, so I just thought we'd look at these questions and see what we think the answers are. These are all true, false. These are questions for chapter 26. I'm sure it'll come back in just a moment. The first question says, one alcoholic drink on occasion is probably safe in pregnancy.
False.
False. That's correct. False. We do not know how much when is okay. I mean, if you ask me, logic says, you're 39 weeks and you want to toast your sister at her wedding. Is that champagne going to hurt you or your fetus? My logic says no, but as a professional, I'd say if you can do without, you can do without. Insulin needs increase during pregnancy.
False.
After delivery or during pregnancy?
Oh, sorry. Insulin needs increase after delivery. Sorry. That's false. Insulin needs increase during pregnancy, and especially during the second and third trimester, because insulin is used to take energy or sugar into the cells, and everything is growing, so we have more cells and bigger cells, so we need lots more energy to go into the cell, so you need more insulin. My daughter-in-law, who's on no insulin since the moment she delivered, gosh, I meant to write down how much she was on, but she's a type 2 diabetic, had never been on insulin before until she was trying to get pregnant. And by the third trimester, by the time she delivered, she was like on 60 units a day or something like that of long-term, like Levemir, and then adjusting it after every meal with rapid acting. And as soon as the fetus was delivered, we have a baby, she hasn't taken one drop of insulin, and her blood sugars are still normal or below 100. Pretty amazing, huh?
Yeah,
Pretty amazing. Is marijuana teratogenic? No, it's not. It can actually affect the sperm of a male, so more likely that would be the problem, would be affecting fertility. Teratogenic means it causes birth defects. And to date, we think that it doesn't. Now, did the fetus decide to, get high and get the munchies? No. So it's still not a good idea, but it's not teratogenic. Again, those studies are very hard to do, so I don't think it's teratogenic, but it may have some behavioral problems. I mean, all these drugs we're going to talk about probably have some impact. Depending again on when they're used, how much they're used, how often they're used, how close to delivery, during what stage, etc. But fetal congenital anomalies are more common in the diabetic mother.
True.
That is true. About 3 times higher congenital anomalies are. If the mom has stable blood sugars, probably they're going to be more like normal people without diabetes. But still, they're higher. But they definitely need to maintain. Hypoglycemia causes sweating and pallor.
True.
There you go, you all knew. The normal heart can adapt to the changes in pregnancy.
True.
Fasting blood sugar greater than 101 is the diagnostic criteria for gestational diabetes.
False.
That's false. There is a number, and right off the top of my head I can't remember, but it's in your book, and when we get to it, we're going to need to remember it, at least until whatever day. Not next week, but the week next week. Mitral valve prolapse requires surgical repair prior to planning a pregnancy.
False.
False. You might wish you had it, had you had one, but not necessary. Infant HIV test can remain positive for up to 18 months due to passive maternal antibodies.
True.
If they do the antibody screen, if they do the DNA PCR screen, no. But the old way we used to do it was by detecting antibodies. And the antibodies will come via the placenta to the fetus and the newborn. So those antibodies will stay around for about 18 months. But all it means is they have antibodies and you don't know whose they are. So it's not a very good test. And our speakers will tell us that even today, they have practicing healthcare providers who are ordering that test on newborns, which isn't helpful really, because it doesn't really tell you if they have the HIV virus or not. So we've moved beyond that. 1 in 10 women report using illicit drugs during pregnancy. Actually, I think it's 1 in 5. I won't ask you that, but still it's pretty common. And this is illicit. That doesn't even take into account tobacco and alcohol, which are not illicit. Illicit means illegal or obtained from other measures other than legal. Okay. All right, good. So that's kind of an introduction to the kinds of things we're going to be seeing here. You're in your 3rd unit. You're 2 major exams away from being in your last semester of nursing school. You're on the train for December 2017. And then to take the biggest test you ever took in your life, but you'll be prepared. If you're talking to the graduates who graduated recently, the ones from Sasha's class and Connor's class who just have taken their NCLEX. Now, people don't usually put on there if they on Facebook if they haven't passed. But I think, and I haven't like pulled out the class roster, but most students have passed. Yeah, so far I think everybody did. And if they haven't taken it yet, the sooner you take it, statistically the more likely you are to pass. Because you're probably going to schedule it. You're going to feel confident, you're ready, you're prepared. You're going to schedule it, okay? So, although I did have a student a few years ago who did not take it. Now there was a rule, there is a rule now, but it's being rescinded, I understand, where you have to take the NCLEX within 6 months after graduation, or you have to remediate. That is in place now. But it is, I'm told from Mrs. Palmberg, they're rescinding that from the Board of Nursing, is doing that. But a few years ago, when that wasn't necessary, we had a graduate here, and she was pregnant, and she was moving, and she didn't want to take it, and she didn't take it for 2 years. And after 2 years, she took it, she passed the first time. So it can happen. Have another guy, not quite as happy story, but he failed it twice. A grown man, had another profession, was probably my age at the time. But his wife was a nurse, and his daughter came after him. And he did not pass the NCLEX the first time, nor did he pass the second time. And he waited until like 2 or 3 months before the 5-year period is up, and at least that was the rule then. And he had to take it. He took it and passed. And is now like a charge nurse in an ICU in one of our local hospitals. So,
wow.
I mean, you can overcome. I tell you that because there are people, I think there are probably, I know there was somebody in our faculty who's retired who used to tell all of her students she didn't pass the NCLEX the first time. And so you can overcome that. So don't go jump off a bridge or anything like that. Don't. Okay, because it's not as good for us if you don't pass the first time, but you get 3 tries before. And if you move to another state and pay to take it there, you can take it again there. Doesn't matter, it's the same exam, so. Yeah.
Just following on the subject, on the ATT, the authorization to test, how soon do we get that after we
Been getting it very soon. Mrs. Palmberg and her staff have done a very good job. As soon as she gets the final grades, she sends your name up to Tallahassee. And I believe you can already send your information up before then. So when they get it, match it together, you'll get it. We've had students graduate in December, I know for sure, who have taken it like the first week of January. And students graduating in May, I know I saw some in early June who were passing in early June. I don't remember about if they were May or not passing, but I know, no, I think they did. I remember somebody who took it right before Memorial Day weekend. So you're getting it pretty quickly, I'd say a couple of weeks.
All right, cool.
As long as they keep doing a good job, which is what they have been doing. Used to be with our old director, not such a pretty story. Okay, so we're going to talk about effects and management of pre-existing diabetes and gestational. Not a lot, but more just how it impacts pregnancy pretty much. And how it impacts the newborn. Talk about heart disease, not a lot, but some. Talk about all of these types of infections and how they might affect the fetus and the newborn and the mother, and then talk about substance use. So classification of diabetes, there's type 1, type 2, gestational diabetes, which is GDM, and there's subcategories. You really don't have to know those. Gestational diabetes is the one that we're most concerned with. However, like my daughter-in-law had type 2, and we're seeing more of those because of obesity, and obesity at a younger age. So those women are borderline, if not already, type 2 diabetic. So type 1, of course, we know are those that usually acquire it as juveniles. It's always insulin dependent. Type 2 can be acquired now, we're seeing as juveniles, and it may or may not be insulin dependent, okay? Different pathologic type or reasons for acquiring it. Do you know what it usually is or presumed to be for type 1?
Type 1 is
It's usually viral, autoimmune type of destruction of the cells. And type 2 is more related to obesity, insulin resistance, and those types of things. So you may have a lot of insulin, but it's resistant to accepting glucose and doing its job. The incidence of gestational diabetes is about 10% of our population, I think, about that. I'm not going to ask you that number, but it's significant enough that we screen every single woman who's in prenatal care for diabetes at one point or another. If we'll talk about that in just a second. If they're high risk, we screen at one time. If they're low risk, we screen at another time. We're making some good progress on identifying those who are gestational diabetics. You can see they're doing some biomarkers, and this is a glycosylated fibronectin. We know the glycosylated hemoglobin, right, is what we measure our hemoglobin A and C on, which pretty much runs the cycle of the life of what? Of a red blood cell. So you don't have to know this, it's in red. It's just that this was not too long ago, and they're able to now look at this biomarker, and 63% of the time when they had this glycosylated fibronectin, 63% positive related to the condition of gestational diabetes. They were able to identify early, before we've ever been able to identify before. So there are just some new changes, I just wanted you to know. If we have a screening test and a diagnostic test. And the way we use these is with the screening test, we will use this for every woman somewhere around 25 to 7 weeks of gestation if they're low risk, okay? And the glucose challenge test, or the screening test, is a non-fasting test. The woman drinks 1 drink of sugary substance that has 30 grams of carb in it, I think. Those numbers just went out of my head. I don't know why. And 1 hour later, we check the blood sugar. Okay? And if that's positive for diabetes, because it's a screening, then they get a diagnostic test. The other way they get a diagnostic test is if they're high risk, and I'll tell you who high risk is in just a second. On the diagnostic one, if their fasting blood sugar is over 126, or the non-fasting level is over 200, then they will also move on then to the oral glucose tolerance test. So some women start out with a glucose challenge test, go to a fasting blood sugar, and then the oral glucose tolerance test. And the oral glucose tolerance test is a 3-hour test where the woman comes fasting for at least 10 to 12 hours prior, and then they draw the blood fasting, and then they drink their sugary substance of about 45 grams of carb, and then do a blood test 1 hour later, 2 hours later, and 3 hours later. You're shaking your head. Did you have that?
Mm-hmm.
Was that fun?
No.
How'd you feel at the end?
Horrible.
How'd you feel at the end of 3 hours?
I feel like I had to throw up.
Shaky,
Yeah.
nervous, starving, sweating.
But I passed.
Yeah, you feel really super hypoglycemic is what you feel like. And you're gonna say what?
I said I passed it. So.
You did pass it, yeah. But yeah, it doesn't matter how you feel at the end. You're gonna feel crappy even if you do pass it.
And when did you say that they first start, what gestational age?
If we're screening low-risk women, we're gonna do it between 25 and 27 weeks. If we have a high-risk woman, we may begin with screening, or we may begin with diagnostic, but we're gonna do it at the very first prenatal visit. Now, who's high risk and who's not? It's almost easier to tell you who's high risk and then everybody else is low. So you're high risk if you have ever had gestational diabetes before. This will probably sound pretty common sense. You're high risk if you have pre-existing diabetes, type 1 or 2. You're high risk if you're obese. You're high risk if you're advanced maternal age. You're high risk if you have hypertension. You're high risk if you had a poor OB outcome before. And that just means something unexpected and not good happened for mom, fetus, or newborn. Did I say obesity? I think yes, you did. And everybody else is low risk.
What about if you have an family?
Family history would make you high risk too. And that might not, it depends on where, like if it was your great-grandmother, might not move you up to early screening, but otherwise it would. So everybody gets screened at some point. The amazing thing I always find about this is, at the very last topic that we talked about in this unit is postpartum depression, or the different psychological changes that occur in the postpartum period of time, which can be OCD-ish and anxiety and other things can also be manifested, although we tend, and even psychosis, but all of those mental health things that are related to the postpartum period of time are probably present in up to 30% of all women. And how many pregnant women are we screening? Very few. Florida Hospital screens before discharge. Their doctors who practice there screen during the pregnancy. They've agreed to do that. And they make follow-up phone calls afterwards. That brings up to a lot of cha-ching, okay? Other hospitals are not doing it because, number one, it's time-consuming. They may not have staff dedicated to it. And it requires, if you get an abnormal, you have to do something with it. You have to follow up. My daughter-in-law had a history of anxiety. Several of those questions asked, have you ever had anxiety? Have you ever felt anxious? Follow up. She told the truth, and she rated high on hers. And so they have done 2 follow-up phone calls to her to see if she's okay. Of course, me, eagle eyes, I'm watching her constantly to see if she's going wacky, you know, but, you know, it's really important, I think, and it just speaks to the lack of respect, I think, that we have as a culture for mental health issues. And probably your mental health instructor would agree, I'm assuming, because it is as dangerous as diabetes is to the fetus, the mother, and certainly to the newborn and the rest of the family, but not screened for on a 100% basis. So, just something to think about. Okay, so what is the effect? These are the effects on the mother, and then we'll look at the effects on the fetus. This is really for pre-existing or gestational diabetes. I will tell you, in gestational diabetes, often we have more control, and we don't have as many serious problems, but that's not always true. So we have increased incidence of preeclampsia. So we have a woman who's 37, having her first child, who's hypertensive. So she's probably going to be, has preeclampsia, she's probably going to be diabetic as well. So these are really, really dangerous patients to have. Ketoacidosis, of course, is only going to occur if what happens? Does your blood sugar get high or low with ketoacidosis?
High, 599.
High. Yes, so if her blood sugar is uncontrolled and high. Now, the definition, I forgot to tell you, of gestational diabetes means that the diabetes was initially diagnosed during pregnancy. So it could be type 2 diabetes that was already there, but nobody had health care and they didn't know it. And I have seen women who come in with type 2 diabetes, well, with gestational diabetes admitted to the hospital for management, let's say, because their blood sugar is like 600. Gestational diabetics don't usually get 600, you know what I'm saying? So probably they already had diabetes, but anyway. Hydramnios, and that's an excessive amount of amniotic fluid, lots of fluid. And what do you think that is? Where does the fluid come from? From the fetus, that's right, mainly from the fetus. And what can the fetus do to make a lot of amniotic fluid? Urinate a lot. And why might the fetus inside a diabetic mother urinate a lot?
Because that's what it's saying.
Because polyuria is one of the symptoms of diabetes, right? Of high blood sugar. And it has to do with the reabsorption of the fluid in the kidneys, depending on the concentration of the urine that's coming through the kidney at that time. So moms who are diabetic often have a lot of excess amniotic fluid. That can be important because it stretches the uterus way out, okay? And that can cause preterm labor and some other problems. But this young woman here definitely has this. I mean, this is the picture, so that's a really, really big pregnancy. Preterm, premature rupture of the membranes, which we're going to talk about probably next week. Prolapsed cord, abnormal labor, and shoulder dystocia. It means this anterior shoulder gets stuck behind the symphysis pubis, and that's usually because of their position in the pelvis, because they're large, because they don't fit in there just right. And that's an emergency. And postpartum hemorrhage, mostly because of the overstretched uterus. So when you overstretch it like a balloon or blow it way out, it's hard for it to get back to its normal state. In the idea of a uterus, it can get back. It's just harder for it to. So that means postpartum hemorrhage is more likely.
God, that's so big.
Now for the fetus, what we have when we have a fetus in a diabetic mother whose blood sugar is anything over normal is basically this fetus is eating at Dunkin' Donuts every day, all day. So they are just sugary sweet, okay? But now remember, this fetus has a normal pancreas, okay? So what will they do in response in utero to eating all those donuts, all that sugar? They will make more insulin, right? And what do I want to say? Shoot it out. What is that? My brain is not good today. Did somebody say eject? Because that's the only word I can think of in my head right now. I thought I heard it. Anyway, secrete more insulin. There we go. There's the big word. So they will secrete more insulin. That's fine in utero because their pancreas is normal. They will secrete however much insulin they need to be normal. Okay, now they might get high blood sugar for a while, and that's why they urinate more. But they're normal in utero. Now, arrive on delivery day, deliver the fetus who's no longer dining at Dunkin' Donuts and no longer has access to donuts. Wants donuts, and their pancreas is still secreting insulin as if they were eating at Dunkin' Donuts. So what's the big risk for this newborn? Hypoglycemia. That's the big problem. So you might have already seen it in clinical, but babies born to diabetic mothers is one of the criteria that we do a fairly soon AccuCheck on a newborn. Because hypoglycemia might be what Tequila, say it right. Tequila, like queen, tequila. I knew what tequila felt. But tequila knew and had the resources to get some food. But the newborn doesn't have that, so their blood sugar drops and drops. And if it drops lower than normal, it can cause irreparable central nervous system damage, i.e. death. Okay? So hypoglycemia for a newborn, big deal. Very big deal. Okay? Look at your protocols when you go to the hospital the next time. Each hospital has one that'll be slightly different. The only one I know is where I go, primarily in a Florida hospital. Once they do an AccuCheck for diabetes, they have to do an AccuCheck before the next 3 feedings on the newborn, and only those if they're normal. And if they're not normal, they will do other interventions and continue checking. Now the deal for that is, the reason we even care is because they do heel sticks to get the blood. Now we know it's the teeniest, tiniest little drop of blood, but the parents don't like that. They don't like their little babies having to get their heel stuck. And if in fact they do have to get it stuck multiple times, sometimes it gets bruised. I've seen them be so nasty looking, and not necessarily from diabetes, but sometimes from hyperbilirubinemia as well and other conditions, that all you have to do to get blood out of that heel is warm it up and squeeze it real good, and you'll get enough blood out for an AccuCheck or a bilirubin check or something like that. So that's not good. You know, we don't want that to happen. So, you know, we want mom to do well, and we want to make sure that we identify these babies once they're born appropriately. Okay? So in the first trimester, the big deal about mom being a diabetic is that they have increased spontaneous abortions and probably related to the increase in congenital anomalies. Probably related. They also have growth issues. Now, look at this. You probably should be saying to yourself, that makes no sense because those are total opposites. Macrosomia is over 4,000 grams. So that's a big baby, over 9 pounds or about 9 pounds. And fetal growth restriction is a fetus that's not growing according to their size. So we do an ultrasound this week, they're 28 weeks. We do an ultrasound in 2 weeks, now they're only 28 and a half weeks. So they're not growing appropriately for whatever reason. Usually, not always, we see macrosomia more in gestational diabetics and fetal growth restriction in those moms who have been long-term type 1 diabetics that already have vascular involvement. So they've been a diabetic since they were 4 or 10 or whatever they were, and insulin dependent. And so I don't know if you've ever looked at these, and you don't have to, but maybe if you see it, you can be aware. And maybe you already know. But diabetes is classified, there's a classification called White's classification. It was in our old textbook, I don't think it's in yours. But it classifies diabetes with letters and numbers according to which organ systems are involved. And the higher you get in the alphabet means you have vascular involvement in your kidneys, in your eyes, in your feet, etc. So, that's important to know. So those types of patients will probably more likely have fetal growth restriction. Now, the neonatal effects. Notice fetal, don't get thrown off. These are fetal effects. These are neonatal. What's the difference? In utero, extrauterine, absolutely. So we already decided they have hypoglycemia. Because of that, they may have hypocalcemia actually due to hyperglycemia or hypoglycemia. Polycythemia, and what is polycythemia?
Too many red blood cells.
Too many red blood cells. Why does the diabetic, baby born to a diabetic mother have too many red blood cells?
Because they use too much energy, which causes hypoglycemia, which...
That's good, but that's not it. So let me. So polycythemia, I believe for newborns, I don't know why I can't remember my numbers today, but I believe it's a hematocrit over 65. Okay, so that's high. Okay, it occurs because mom likes to hold on to her own oxygen. Her glycosylated hemoglobin has an affinity for her oxygen, meaning it wants to keep all of its oxygen. It doesn't break the bond and give it up as easily to the fetus as a non-diabetic mother. Okay? So the glycosylated hemoglobin of the mother has an affinity for its own oxygen and does not want to break the bond and give up the oxygen to the fetus as easily. So the fetus says, I'll just make more red blood cells. Not a problem. I'll handle it on my own. We'll just be independent from conception, no problem. Okay? Hyperbilirubinemia can also occur, and why?